PAH.TV coverage of CHEST 2015 in Montreal continues. Thomas Baldrick, happy to have with us Dr. Vic Tapson, now of Cedars Sinai in Los Angeles. How are you liking it there?
I like it, Tom. Been out there for about almost 2 years now. Time flies. I still miss Duke a lot, but Cedars is a great hospital, 1,000 beds. We're getting some good pulmonary hypertension and pulmonary embolism studies going, so it's working out great.
It's all good. Let's talk about the INFORM study. First off, why was it even necessary?
Well, I think one of the problems with this disease, pulmonary hypertension, and pulmonary embolism, this is kind of one topic, kind of links PE with pulmonary hypertension. We know a certain percentage of patients with pulmonary embolism go on to get chronic PH, chronic pulmonary embolism causing PH, and could die from it. And they often believe they're underdiagnosed. So we kind of want to get a better sense. We have some data from years ago from the PENGO study, a nice New England Journal paper, European study, that found about 3.8% of patients who have acute PE and are followed longer term go on to get pulmonary hypertension. In the US, if you had, we have a couple 100,000 acute PEs that survive every year. There's more than that. There's hundreds of thousands of patients, which means there's got to be 8, 10, 12, 15,000 patients with chronic PE in theory every year. So we want to get a better sense for how often patients were going on from acute PE to pulmonary hypertension caused by chronic PE.
What did you find?
So we found an INFORM study, and this was a retrospective study, kind of hoping to generate some information, a hypothesis. The retrospective study, we looked at a health claims database and found about 7,000 patients that had acute PE, and we looked at PE, PH symptoms, shortness of breath, chest pain, things that might be symptoms in patients with pulmonary hypertension. We extracted data on echocardiograms, caths, right heart caths, as much information we could. We found about 6.2% of patients looked like they probably had PH after having an incident pulmonary embolism case. And many of them did not have any imaging follow-up. Many of them had symptoms of pulmonary hypertension without getting any imaging follow-up. So that was concerning. So I think what we need to do now is we need probably a little more data, more solid data on what's happening to these patients. You know, follow some of the acute PE, how often they go out and get chronic PE, where are these patients? We have drug therapy for chronic thromboembolic pulmonary hypertension now. We not only anticoagulate those patients, but if they're not candidates for pulmonary endarterectomy, then we consider putting them on therapy like riociguat, the only FDA-approved drug we have now for CTEPH. Inoperable patients or patients who are operated on and have residual pulmonary hypertension. So there's something we can do for these folks, so we kind of want to find them.
What was most surprising about your data?
I think the surprising thing was that 6.2% is a pretty high number. 6.2% of patients with acute PE, instant PE, having evidence of PH. Now, what I have to say is we don't have as much detail on these patients as we would if we done a prospective study. But if it was half that number, it's still a high number, and that still means there's thousands of patients out there. You talk to my pulmonary colleagues, my cardiology colleagues, we're not seeing that many patients out there. So they're somewhere. They're getting diagnosed with PE, and maybe they're still short of breath, and they think it's because of their PE still. In fact, they may have chronic problems. So we've got to raise awareness, I think. Raise awareness to someone who has shortness of breath that persists after an acute PE. Do they have CTEPH, or chronic thromboembolic pulmonary hypertension?
Your opinion, when you have a patient diagnosed with PH, what's next? What are the options?
So the important thing with what I tell patients, we need to know the cause, we need to know the severity. You know, both of those, and we can start therapy. Very sick patients with idiopathic PH or pulmonary arterial hypertension, they may get put on a parenteral therapy, an IV or sub-Q pump. Less severely ill patients, we put on oral therapy. So that's really important to be able to decide on what specific therapy. We also got to make sure we do rule out other causes. So a VQ scan is one of the things we do in patients that are diagnosed with PH. Whatever the perceived cause, we do a VQ scan. It's a great screen. If it's abnormal, high probability, we follow it up with a CT, and if we find CTEPH, we consider surgery. It's a treatable, curable condition. So that's the key, cause and severity.
What will you be doing next with this research?
Well, I think what would be great to do is get a prospective database. We have a CTEPH registry underway right now. We're looking into doing a prospective study that's much like the PENGO study, taking patients with acute PE and following them prospectively and proving this hypothesis. There are a lot of patients going on to get chronic PE that we don't know about. So I think that's the next step. And in addition to perhaps doing another registry or study, I think just finding ways to raise awareness, making sure we talk to our pulmonary and cardiology colleagues who may see these folks, and make sure they're thinking about this topic, thinking about the possibility of PH, and referring them to a center that does pulmonary thromboendarterectomy if the patient does have it. If they're not sure, send them. The CT scans are hard to read, Tom. The VQ scans are easier. The CT scans, if you're not an expert in that area, trying to determine if someone has CTEPH, if they're operable, is not so easy. So I think it takes some expert opinion.
Very good. Trip to Cedars Sinai in Los Angeles be a nice little vacation too.
Yeah, absolutely.
Thanks for your time. Appreciate
Thanks,
it.
Tom. Nice to see you guys.